Good morning. My name is Barbara Jarząb. Together with Dr. J Krajewska, we shall show you an educational talk about anaplastic thyroid cancer. First, I shall give my introduction, and then Jolanta will show some case descriptions. So I start my talk. The issue with thyroid cancer is that it is a rare disease. However, anaplastic thyroid cancer belongs to ultra-rare diseases. Among all histotypes shown on these slides, it constitutes not more than 1.6% of cases. And anaplastic thyroid cancer is an aggressive disease. It is seen sometimes more frequently worldwide, and the difference lies probably in this, that anaplastic thyroid cancer is an aggressive disease, as I told you, and it is distinctly diagnosed, while the other histotypes of thyroid cancer are milder, and they can be diagnosed not adequately. The overall survival is less than 12 months, and only 20 to 40% survive 1 year. And this is mainly due to the low overall response rate to standard therapies, which is less than 15%. And anaplastic thyroid cancer is unfortunately diagnosed in late stage. And according to the American Joint Committee on Cancer criteria, if we see anaplastic thyroid cancer and diagnose it cytologically or histologically, it is always stage 4. Stage 4A, if the tumor is confined to the thyroid gland, but it happens rarely, only in 10%. And 4B, if any extension is seen outside the thyroid gland, like infiltration through thyroid capsule or neck lymph node metastasis. And 4C is, of course, distant metastasis, which unfortunately is diagnosed most frequently in nearly 70% of cases. And if we face a patient with a rapidly growing tumor of the neck, we should always think about anaplastic thyroid cancer and perform immediately a biopsy, either fine needle biopsy, or when it does not bring an unequivocal result, we should proceed to core biopsy. However, I should warn you, core biopsy is difficult and dangerous. We should be aware of high bleeding risk. Thus, the core biopsy should be performed only in experienced centers. And when we have the diagnosis of anaplastic thyroid cancer, either histological one or cytological one, we should perform diagnostic procedures, which are listed on this slide. I shall focus only on the crucial ones. Laryngoscopy, including evaluation of vocal cord mobility, and in case of airway invasion, NCCN advises bronchoscopy. And once we have the patency of the airway established, we should proceed to molecular testing for actionable mutations, before all BRAF mutations. I shall go into details later on. And at this moment, we have to establish goals of therapy by expedient consultation with multidisciplinary management team, followed by discussion of prognosis, risk, and benefits of treatment options, including palliative care options, which encompass airway management. Let me explain that until 2015 or 2018, the diagnosis of anaplastic thyroid cancer was very frustrating for the physician. It was demotivating for surgeons who knew that even an extensive operation, which is very difficult, will not bring any long-lived success. The tumors would recur and lead to unavoidable death. Also, radiotherapists were frustrated because they were aware that they have no means to stop the disease and to rescue the patient from the quickly coming death. However, the situation changed in 2018 with the publication of the first clinical trial with dabrafenib and trametinib. This treatment addressed the BRAF mutation, and it gave a chance to prolong the life of our patients. However, on this slide, Dr. Cabanillas from MD Anderson Cancer Center proposed a flow chart. What we should always do if we face the patient with a rapidly expanding neck mass and suspect anaplastic thyroid cancer. So it is very essential to immediately triage the patient and assess patency of airway and secure it. After that, we should refer urgently to tertiary care center, subspecialized team, if possible, of course. And this team will perform neck imaging or imaging-guided biopsy, as I told you, fine needle aspiration or core biopsy. And if we have confirmed the diagnosis of anaplastic thyroid cancer, either cytological or histological, we should perform all of the below procedures in parallel. Thus, if the suspicion of anaplastic thyroid cancer is very high, we should go to a rapid assessment for actionable genetic tumor mutations, before all BRAF mutation. And when we have more time, we should focus on pathologic assessment to perform differential diagnosis of this undifferentiated neoplasm and to clearly differentiate ATC from lymphoma of the thyroid gland, from metastasis of other rapidly growing cancer, from sarcoma, from squamous cell carcinoma of lung, head, or neck, and other malignancies should be considered, as well as some benign conditions. For example, hemorrhage into thyroid cyst, which is easily assessed with ultrasonography. So we have already the diagnosis of anaplastic thyroid cancer. And now anatomical and functional imaging should proceed with FDG PET CT or MRI with contrast of neck, chest, abdomen and pelvis, and of course, brain. And while we have established goals of care, we should comprehensively discuss treatment options and define initial care plan. And of course, this discussion should be performed not only with multidisciplinary team, however, also with patients. And we should discuss therapeutic options and potential positive and negative outcomes. I have stressed that quick assessment of the presence of BRAF mutation is necessary. This is mostly and optimally done by molecular tools. However, if our pathology lab is not has not tools to perform this diagnosis quickly, we may use BRAF immunohistochemistry. And the example of such immunohistochemistry is shown on this slide. On the case of papillary thyroid cancer, which was BRAF V600E positive. The antibody against the protein product of the mutated BRAF gene was applied, and we see that the results were much better in the cell block state with the antibody compared to fine needle aspiration smear directly stained with this antibody. However, we should be also aware of the false positive results risks. And you see this on this example, when we see false positive staining in direct FNAB smear, while in the cell block, no staining was demonstrated. And I should stress, time to molecular diagnosis impacts the outcome of anaplastic thyroid cancer. Dr. Cabanillas showed that in MD Anderson Cancer Center in years 2010 to 2014, as many as nearly 23% of patients were dead within 60 days of their first visit. Thus, the fast track is necessary to introduce in your hospital for all ATC patients. And such fast track in MD Anderson Center performed with the assumption that the molecular diagnosis should be performed not longer than 2 weeks, resulted in median 21 days of diagnosis, sufficiently enough to treat the patient. And this slide shows the recent management guidelines in anaplastic thyroid cancer prepared by American Thyroid Association. As we see, in stage 4A, we should encourage definitive intention therapy because the potential for long-term survival for 4A patients is sufficiently high. However, also in 4B patients, we should evaluate whether the tumor is resectable. And if yes, immediately refer to surgery. The goal of the thyroid surgery is RZO, R1 resection. However, we should avoid the bulking because the tumors recur very quickly. Also, laryngectomy is not recommended because of the necessity of to ensure good quality of life. And after surgery, definitive intention radiation therapy should be considered. However, it is possible, probably not only in 4A patients. In other cases, we have palliative radiation option. And if the molecular diagnosis is negative, we stay with palliative chemotherapy and or radiation. However, we have to ensure best supportive care. And in 4C stage, the procedures are similar. Clinical trials are strongly recommended, if of course available. However, we should consider consolidative therapy as feasible, and best supportive care is necessary. Now, let me focus on molecular alterations-driven management of anaplastic thyroid cancer. As I told you, the first mutation which was detected to be addressed with treatment was BRAF V600E mutation. And she enabled the treatment of dabrafenib, and with dabrafenib, a selective inhibitor of BRAF, and trametinib, a MEK inhibitor. However, the first American and Korean results were quite optimistic, and they showed that BRAF mutation may be found even in as many as 50% of patients of ATC. Nevertheless, the later experience, especially European experience, was not so optimistic. In France, only in 18% of patients, anaplastic thyroid cancer patients were found to be BRAF positive. And our experience in Gliwice is very similar. I shall discuss the other molecular alterations management later on. Now I shall focus on dabrafenib and trametinib treatment. It has been described for the first time in 2018 in 36 ATC patients who were recruited within phase 2 basket trial done for evaluation of activity of the treatment and its safety. And all the patients had measurable disease according to RECIST 1.1. They were in a rather good status. Majority of them were ECOG 1 stage. And the time since diagnosis was rather long, 125 days. And this was probably the reason why the patient, nearly all patients were stage 4C. However, they retained the ability to swallow medications. All were previously treated by surgery and radiotherapy, and some received previous chemotherapy. Median of observation was 47 weeks, and the results were surprisingly good. Complete remission was seen in even 3 patients. You see this by green bars. The majority showed partial remission, which is shown by yellow bars. However, many patients were also with stable disease, violet bars. and only 2 demonstrated progressive disease, blue bar. And the rare oncology agnostic research was summed up with the overall response rate, which was in ATC, shown here by the arrow, 56%, quite satisfactory, comparable to other rare cancers. And the water plot shows quite satisfactory response. It shows the best confirmed response. I choose here the first cohort of patients treated with dabrafenib and trametinib. These were 16 patients, and 15 were evaluable for outcome. And you may see the complete response was seen in 1, majority of partial response, and only 1 of progressive disease. And here you see the examples of computer tomography scans. The upper row shows baseline results, and the lower row shows the response at 8 weeks on therapy. And you may see that there are very visible reduction, even complete response. Please note that even in this very advanced anaplastic thyroid cancer with extensive ulceration, after 4 weeks of therapy, a satisfactory response was observed by Dr. Cabanillas in MD Anderson Cancer Center. And in 2023, the results of rare oncology agnostic research trial were summarized in Nature Medicine. And you may see that the results, after sufficiently long observation, were rather short-lived, as you may judge from these Kaplan-Meier curves. However, the objective response was observed in 69%, in 7 patients, even durable responses. And after a year, there was objective response in 19% of patients. Progression-free survival was 79%, and overall survival 80%. However, there were also some risk to be considered, especially risk of secondary skin malignancies. And this swimmer plot shows us the satisfactory results of rare oncology agnostic research. Please note that the best confirmed response was even up to 280 weeks, even 4 years after application of dabrafenib and trametinib. And the median overall survival was 14.5 months, and 12 months survival was reached in 51.7% of patients, and even 24 months survival in 31.5% of patients. Of course, there were adverse events, most frequently fatigue, fever, nausea, anemia, and severe adverse events were pneumonia, pleural effusion, acute renal damage, and rhabdomyolysis, fever, hyponatremia, and neutropenia. However, we may evaluate this dabrafenib and trametinib treatment as relatively safe. It could be even applied as neoadjuvant treatment, as shown in this report in JAMA Oncology from 2020. And you see that this treatment enabled surgery in many patients and significantly prolonged the duration of life. However, as we already know, BRAF mutation, BRAF mutation is not always found in anaplastic thyroid cancer. And then we have to look for other molecular alterations, especially fusions, NTRK fusions, ALK fusion, RET fusions. All these mutations are actionable mutations, and we have drugs to address them. Let me show the examples. In a libretto trial, which evaluated selpercatinib, a RET fusion inhibitor, there was one patient with anaplastic thyroid cancer, violet bar, and he responded very well with some maximum change in tumor size larger than 40%. The same was observed by treatment with larotrectinib, an NTRK fusion inhibitor. The violet bars showed ATC patients, and we see that 3 objective responses were obtained. And of course, these responses were short-lived. However, they enabled time for looking other options of treatment. If we see no mutations in tumors of our ATC patients, we should look for other molecular features like microsatellite instability, deficient mismatch repair, and tumor mutational burden. And all these features are found by NGS, and they are positive markers to introduce immunotherapy of ATC. Here, I present the results of immunotherapy trial performed by John Capdeville et al. With spartalizumab, which is anti-programmed death receptor 1 antibody. And please note that even low 1% expression PD-L1 was sufficient to observe an objective response. This is shown by this blue bar. And in total, in these 42 patients, they observed 19% of objective response. Of course, we are aware that anaplastic thyroid cancer is characterized by rare incidence, high aggressiveness, and poor prognosis. And often, we do not find any actionable mutation. And thus, we have to stay with chemotherapy. Paclitaxel, doxorubicin, carboplatin, and cisplatin are drugs mostly used in chemotherapy of ATC. Doxorubicin and plus cisplatin chemotherapy has been introduced since 1985, and the median overall survival is 6 months, and an objective response rate up to 26%. And in terms of taxane-based treatments, overall survival is similar, nearly 6 months. However, the objective response rate is higher, over 50%. Other chemotherapy drugs like mitoxantrone, cyclophosphamide, or fluorouracil do not give optimistic results. No substantial improvements were identified when ATC patients were treated with these drugs. However, we may think about the new drugs elaborated for rare solid tumors or hematological cancers, like antibody drug conjugates shown on this slide. However, they were not investigated in anaplastic thyroid cancer. Nevertheless, radiotherapy is critically essential for ATC patients to achieve local disease control, since a rapidly growing neck mass can cause asphyxiation. And reasonable palliative radiotherapy may bring unexpected benefits for patients with locally advanced ATC. Slowly, I'm coming to final conclusion. The total lifetime remains with 6 months, even if targeted therapy, immunotherapy, or radiotherapy are added, and disease control rate remains about 60%. And to overcome the issues, basic researchers and physicians still need to do numerous exploration. However, despite this not very optimistic message, please take home message. React quickly if you face with ATC patients. Do not delay the management. Build the fast track in your hospital to obtain the molecular diagnosis quickly. Remember about clinical trials. And what is even most important, do not be frustrated with an ATC patient because he or she needs your help. Even if you inform the family of your patient or patient himself about poor prognosis. I thank you for your attention, and now I invite you to a presentation of ATC cases which will be done by Dr. Jolanta Krajewska.
Thank you very much for giving me a possibility to present these cases. I am an endocrinologist who is involved in the treatment of thyroid cancer, particularly in the treatment of anaplastic thyroid cancer. Here I would like to present you 2 cases. The first one is a 65-year-old male who is born in 1958. The patients had first symptoms of the disease last year in April 2023. It was a neck tumor showing rapid growth within 2 months. This the tumor involved the thyroid and lymph nodes, which were metastatic and localized on the right side of the neck. The patients experienced exercise-associated dyspnea and stridor due to tracheal compression. The biopsy was conducted on June 2023, and the diagnosis was anaplastic thyroid carcinoma. Immediately after biopsy, the patient underwent CT evaluation, and we found neoplastic infiltration of the whole thyroid gland, what you may see on this picture. This neoplastic infiltration led to tracheal compression. The maximum tracheal lumen was only 5 millimeters. Neoplastic mediastinum infiltration 5 centimeters in diameter, and neck lymph node metastasis mainly on the right side of the neck, and as well as multiple lung metastases. The patient was referred to surgical assessment. However, he was not eligible for surgery. The molecular biopsy done also in June 2023 revealed BRAF mutation in tumor cells. So, as you know from the previous lecture, it was a basis for the treatment of combined treatment of dabrafenib and trametinib, and the treatment was started as soon as it was possible in July 2023, and is still ongoing. When you see this initial treatment, initial advancement of the disease, you see the thyroid and mediastinal infiltration here and here, single lung metastasis. No, the patient had no important history, only hypothyroidism and hypertension. So the treatment was started on July 2023. 2 weeks after the treatment start, the patient's general condition substantially improved. There were no dyspnea, no stridor, and very good treatment tolerance. Within 2 weeks of first 2 weeks of treatment, only 2 episodes of fever above 38% were observed. No other no other adverse reactions. The subsequent CT scan performed 2 months after treatment start showed partial regression of the disease. Of course, we still have neoplastic infiltration of the whole thyroid gland, but the reduction was size is noticed. Tracheal compression disappeared. At this examination, the maximum tracheal lumen was diameter was 9 millimeters. Neoplastic mediastinum infiltration decreased up to 35 millimeters in diameters, as well as neck lymph nodes metastasis decrease in size. We have also response from multiple lung metastases. And what you see on these pictures, here you have neck infiltration, which much wider trachea, total remission in lung metastasis, and this status noticed in September last year has been stable until now. However, in a CT scan performed in December last year, a single retropharyngeal lymph node was noticed, and it is not so big, only 9 millimeters in diameters, but it could be the first symptom of disease progression. We performed another CT scan. However, the reporting is pending. We do not know the assessment yet. For the whole treatment time, the treatment tolerance is very good. We observed only some fever episodes. Still, no dyspnea, no stridor. The patient is a very good clinical stage. So this is the confirmation of a very promising treatment response to combined treatment with dabrafenib in trametinib in BRAF positive patient. And another case, a second case, it is a case of a 68-year-old female born 1955, who was diagnosed with anaplastic thyroid cancer in 2021. So 3 years ago, she underwent surgical treatment. It was possible in this case. This surgical treatment involved total thyroidectomy with central neck dissection. However, it was R1 resection because the histopathological margins were positive. Histopathological examination confirmed anaplastic thyroid carcinoma, and just after this confirmation, we conducted molecular analysis, and in some but not all tumor cells, BRAF mutation was found. Initial CT scan revealed residual neoplastic mass in the thyroid bed on the left side, 35 by 15 millimeters, and only 3 micrometastases in the lungs, the largest one 9 millimeters in diameter. Because at that time we did not have an access to dabrafenib and trametinib in Poland, we decided to give her chemotherapy based on doxorubicin, and the patient received in total 8 cycles with the best response of partial regression. And what is most important, after finishing of chemotherapy, the status of patient is still stable. No new disease lesion in CT scan. The most recent CT scan performed on February this year showed complete response in the neck and partial response in of the lung metastasis. And this picture was comparable with the CT scan performed on February 20 and 22. So the patient who received only conventional radiotherapy is still stable with unexpected very good response. These 2 cases are present here, are the cases when the treatment was possible, and the treatment, if effective, particularly in the second patient. But you know that sometimes everything depends on the patient's condition. When the patient is referred for the first time, sometimes this condition is very poor with serious dyspnea requiring immediate tracheostomy. But even in such cases, we have to search for any treatment possibilities, particularly for molecular targeted treatment possibilities by NGS examination of the tumor sample. And if it is possible, we have to search for the possibility to treat the patient under clinical trial. We do not have so far any experience with immunotherapy in anaplastic thyroid cancer. but we plan to start the treatment with pembrolizumab if the patient is BRAF negative, as this drug is currently recommended by the guidelines of European Society for Medical Oncology, with also promising results. Thank you so much.